Hello, my name is Ramanjit Kaur. I'm a nurse practitioner student. So here I'll be doing your examination on thorax, which is your lungs, and your cardiovascular examination. Okay, can you tell me your name
My name is Summer Dhaliwal.
and your date of birth?
September 1st, 2014.
Okay, and what brought you here?
For my physical
Examination. Okay.
examination.
Okay, and tell me what year is it?
It is 2024.
Okay, good. So the patient is alert oriented ×4 and patient is in good hygiene and well groomed. Patient is here for her physical examination, but we'll be doing her lung assessment and cardiovascular examination in this video. So we would be doing inspecting, palpating, and percussing and osculating. So and first, I will inspect the patient anterior chest to see if a patient has any issue with her chest moving. The patient chest is moving symmetrical. I don't see any abnormality sign here. And patient is breathing is fine. I will check patient respiratory rate, and I would listen to patient breath sounds. I would observe any abnormalities if a patient is using any intercostal muscles or abdominal muscles to breathe. And then also we'll be doing a shape and movement of the chest, which is during patient inhalation and exhale, and check for if the patient chest is barrel shaped. Note any asymmetrical anterior and posterior during inhalation or exhalation. And are we doing patient chest expansion? Go ahead, Summer, take a deep breath. Okay, patient, okay, exhale. That's I'm checking for chest expansion, how the patient chest is moving. So it's moving asymmetrical. Also, I'll be checking posterior part of chest expansion, if it's moving symmetrical or if there's any abnormal findings presence. So next, I'll be doing a tactile firmitis. This will be like I'm checking, asking patient, say 99. I'm checking for any it's a vibration of sound that I should be getting. I should be. I'll first let's check. Someone say 99.
99.
99.
99.
99.
99. 99.
Okay, so I have noticed equal and moderate vibration during patient speech. And the next step is so we're doing a percussion of her anterior chest. So I'll be using my DIP joints to percuss. And I should be hearing no dull sound. And I'll also be percussing anterior and posterior, and which should be resonance sound, because our lungs are air filled, so I shouldn't be hearing any dullness. If I hear any dullness, that means I'm on the bony promises area. And the next will be doing diaphragmatic exertion, and which is I'll do it posteriorly. Some turn around. Okay. Exertion means how the diaphragm of the patient is moving, and if I have a pencil, I would be marking the area of exertion. Okay, so I'm going to start with percussing, and see from resonance to dullness area. And then I would be marking my landing area with the pencil, and same from I can do from up top to bottom and bottom to top to see how the diaphragmatic exertion, and it should be normal 3 to 5 centimeters in adults finding. And I should be listening to posterior breath sounds. And so I'm going to take a deep breath. One more. Take a deep breath. Deep breath. One more. One more. Good. And I haven't heard any crackles and wheezing, which is would be abnormal finding, and no adventitious sounds. And the patient had a vesicular sound over the lung areas. And the next I would be doing a gophony and a bronchophony and a pectorum. And then for the pectoral, okay, that's a whispering sound. So I would be asking the patient to say 1, 2, 3, and then Summer, say 1, 2, 3. Okay, when I put the stethoscope, say 1, 2, 3.
Okay. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay. Then I have heard the muffle and distant sounds, which is a normal founding. And then we'll be doing a bronchophony, and then I would ask the patient to say 99, and then I should be not hearing clear sound, which is because that would be a consultation. So if I hear the clear 99, but it should be muffled and distance, which is throughout the chest wall, which is a normal finding. So when I put a stethoscope, say 99, okay?
Yes, ma'am. 99. 99. 99. 99. 99. 99.
Okay. So I have heard a muffled and distant sound, which is present in this patient. And the next one, a gophony. Then I would ask the patient to say E, and then I should be hearing back E sound. And if I hear any A sound, which is could be abnormal finding, so which patient requires a further investigation. Okay, Summer, when I put a stethoscope, say E, okay?
Okay.
Turn around this.
E. 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 E.
Okay. So I haven't heard any other sound except E's, so which is normal finding in this patient. And also, let's look at the patient anterior chest wall. Take a deep breath, exam, like a patient chest is rising symmetrical, the weight and the rhythms and everything looks normal. Those are the normal finding. And then the same we did the tactile parameters, checking 99, and the feeling for the vibration of the sound. And then we have percussed patient anterior chest with the DIP joint, and we should be hearing resonance sounds, not dull. If we hear any dull sound, that means we are on the bony area or we are on the scapular. Let's turn around someone. Let's turn this way. So I'll be percussing with my, so it's just mark your landing away from the scapular area so you don't hear any dullness. Okay, turn around. And then next we will be hearing anterior breath sounds, and then it should be the quality of anterior breath sound. It should be soft, low pitched. There should be not any crackles, any other adventious sounds. That means that would cause further investigation if we find any other like a crackles or wails, anything. So around the trachea area we'll be finding high pitched sounds. And then when we come to the midline, and then we'll be finding a bronchovesicular, and the lower lobe of the lungs we have a vesicular sounds, which is a low pitched, soft and breezy, and they are over the peripheral lung areas. So take a deep breath. Okay. Sometimes during assessment, if the patient have a larger chest, you can ask patient a patient to lift up their breast so you can assess the lower areas. And here we go. So I have inspected the anterior and posterior chest to see if there is any bruising, anything I have abnormality noticed, but I haven't seen on the anterior and the posterior chest. And then I'm gonna do a tactile fremitus on the posterior chest. Summer, say 99.
99, 99, 99, 99, 99, 99.
Okay, I haven't seen any abnormalities. I have heard the vibration sound of the words, and no bruising sign, nothing that I have to be careful about it. And next we'll move to cardiovascular examination, which is I'll be doing a jugular venous pressure, and the next is carotid pulse. So for the jugular venous pressure, I would ask the patient to lay down for 30 to 45-degree angle so we can easily observe jugular venous. So sometimes the tunnel jugular vein is too deep, so they are hard to see. So it depends on the patient. Sometimes you can move the bed in order to see or assess better observation for jugular venous, internal jugular venous vein. So here we ask the patient to lay down. You can either stand on the left side or the right side. Come down a little bit. Okay. And turn your head on the other side. So we'll ask the patient to turn their head. And if you don't see, you can always adjust your bed. And then you will also find the sternal notch, and then jugular vein, of course, the side of the neck, and the measure. You can measure the vertical distance between the sternal angle, which is also called the angle of Lewis. And then you need to get two tools. You can get a tongue depressor and the measuring tape, and see the highest point of pressure of your jugular vein, and then a sternal notch, and then you see sometimes it's just a lower and I find right here. Sometimes you can get a light so you can see the jugular vein popping with the light, flashing light. So I see it here, so which I'm gonna measure. sorry. So I just measure it like a it's a 1.5, which is normal, less than a 4. It could be a 3 to 4 centimeter. You can set somewhere 3 to 4 centimeter above the sternal angle. But if it's a greater than a 4, then that would be abnormal finding, which can show the cardiac problems such as right heart failure, have a seat, or fluid overload. You can also check the pulse waveform with the fingertip, AV, and then the next will be doing carotid pulse. For carotid pulse, you can ask the patient to sit or spine. Either way. Let me fix my camera. Sit or spine. So the carotid pulses are on both sides. So we should be assessing one carotid pulse at a time. And then there's also carotid sinuses, and if we rub on them, then that can also cause a blood pressure problem. Yeah, I'm gonna sit here in the chair. Blood pressure problem in the patient that can lower the blood pressure. So we'll checking carotid pulse one at a time, and then it could be they are the either side of the neck. So they are medial to sternocleidomastoid muscle below the angle of the jaw. Here you can feel. Okay, I'm gonna assess the other one just with your index and middle finger. And you can also palpate them for any thrill. That means there's any turbulence, blood flow, and means narrowing of the arteries. Then it could be in a middle-aged man, the patient who are suffering with the cardiovascular issues, and then they need a further assessment if you palpate anything that shouldn't be normal finding. But I don't see any abnormality here. Or everything seems to be a normal finding in this patient, Summer. And you always apply a little pressure, firm pressure. You don't need to put too much pressure on to overstimulate those arteries. And then I can also listen with my diaphragm and with the valve for the buoy. Yeah. I don't see any abnormality. The pulse, the strength, rhythm, they are regular, they are normal, they are not bounding. And then, yeah, of course, one at a time, not jeopardizing the patient brain blood flow. And then if there is any abnormalities noted, we're gonna do further investigation, and or if there is any weak pulses or bounding pulses, or of course absent pulses, and that requires attention, medical provider attention. And the next will be doing brachial arteries. Brachial arteries, they can find in our antecubital fossa, and it's on the both side. We usually assess them for blood pressure, and then patient can sit and they can extend their arms, so we can locate antecubital fossa and the brachial arteries in the cubital groove. So I would take my index and middle finger to assess patient brachial arteries, and you can feel when you apply the pressure, you can feel the pulsation apart. You don't have to put too much pressure just to occlude the artery completely. You can check pulse strength, their rhythm, and regularity to see what's normal and abnormal. Are they weak? Are they bounding? Are they normal? How regular they are. And then you can also check here on the same time on the other arms and the cubital fossa to see if you have any regularity. Notice, because it can cause any cardiovascular complication in the patient blood pressure if there is a one side you see abnormality that shouldn't be there, such as a weak, if their one side pulses are weak but other side pulses are normal. So maybe the one side the cardiovascular system is compromised, the blood flow compromised. So we need to further investigate to see what's going on that side. But I don't see any abnormality in this patient. So we'll move to our next step. The next step would be our point of maximum impulses. For also, again, for this position, the patient, you can expose patient chest to see better your landmark area. Patient can sit, or sometimes patient can be on their left side, but you need to access the patient mid-clavicular line to access your point of maximum impulses, which can be located on the left intercostal gap. So we'll follow the midline here, and then we go to the mid-clavicular. The left is always on the left side of the chest. It can be palpated and located. So you can use your index finger or middle finger. Sometimes some provider like to use their palm, and it should be on the apex of the heart, fifth intercostal mid-clavicular line. That's your landmark area. So you come the mid-clavicular at the apex of the heart, and then palpate here with your two fingers to feel for the PMI, the corresponding systole. You can feel when the heart is the strongest. Sometimes you can ask the patient to exhale and hold their breath just to better understand PMI. So, but you can just palpate here under the apex of the heart on the left fifth intercostal space. And then you can also check the location and the size, and if there is any abnormalities present there shouldn't be there. And if you feel that required a further diagnostic exam, for example, some PMI displacement, heart enlargement, and then you always want to mark your landmark area, mark your location, as such as the sternum of the sternum or nipple. So, but I haven't seen any abnormalities in the PMI here. If there is any abnormalities in the patient PMI size, strength, or the place of the PMI, that of course we need to rule out any cardiac abnormalities to see what need to be done. But the PMI is here, the mid-clavicular, the apex of the heart, and the fifth intercostal. Okay, and the next we'll move to the thrill or the broody. Of course, we have said before, the thrill is if there is any turbulence, blood flow, narrowing of the arteries, that would feel like a cat furry type of feeling, and then of course you listen for the bruit, yes, bruit sound with your diaphragm and the stethoscope. You can go to your major arteries, the carotid arteries, your femoral arteries, and to detect through your abdominal aorta, your subclavian arteries. You can assess them, palpate with your index and middle finger, and then you can also assess for thrill, palpate for thrill if there is a narrowing, a stenosis of any arteries causing blood flow circulation problem. Then to detect any bruit, just to find the arteries and just to palpate the arteries, listen with the stethoscope, with the diaphragm and the bell, just to better understand. So here we'll do the carotid arteries. We'll use with the index and the middle finger and palpate and see if we feel any thrill, like a cat furring type of feeling. And then you can use the both on the other side as well. And then again we can listen with our stethoscope the bruit sound, like a swishing sound. I don't see any abnormality noticed in this patient. No thrill. Looks like a patient has a normal blood flow. And but if I feel anything causing arteries narrowing, then of course we wanna investigate that further. And then we will listen to patient heart sound, and I would assess patient aortic area, pulmonic area, and the tricuspid area, which is we'll start with the second right intercostal, and the patient the second right intercostal. We can go to the aortic area right here, and then a pulmonic area on the second right intercostal space on the left side. And then we'll move to patient fourth area, which is the tricuspid area, and the fifth is intercostal, which is the mid clavicle, which is the mitral area. So these are the landmark area: aortic, pulmonic, tricuspid, and mitral valve. So the four areas of the land. So we will auscultate with our stethoscope, and I would ask always a patient to need to breathe normal. There's nothing to worry about. Just checking with a heart sound with the stethoscope. So we'll go with the aortic area, pulmonic, tricuspid, the apex of the mitral valve. So we should always pay a little bit close attention to the first and the second heart sound, which is S1 at each location. The closer of the tricuspid and mitral valves during diastole that represent S2. So whereas the closer of the aortic and the pulmonic valve during systole, which occurs during systole. I didn't see any abnormal finding in this patient. S1, S2, and there's no abnormal sound, heart sound that would cause any issues. But if there is one, like sometimes the S3, S4 can be present, but there requires investigation. Some patients have like a aortic murmur. So when we assess patient jugular vein, so you can also see aortic murmur sense palpation here with the internal jugular vein SS, but you can always go back and check what's happening with the patient health, but there should be any extra sounds present that would cause abnormal finding and indicate heart failure or any cardiovascular issues, cardiac abnormalities, valvular disorder, which means there's something going on with the patient heart valves. They are not closing properly, and what needs to be done. So them requires further investigation, more diagnostic tests, special provider interference. So in this patient, we did a thorax and a cardiovascular examination, which is the chest size, the patient heart rate, patient respiratory rate, rhythm, everything is normal. Patient chest anterior and posterior moving, no sign of a bruising, anything find abnormalities. I haven't seen anything, and the patient, the cardiovascular exam is normal. That doesn't require any further investigation at this point. But of course, we always do health promotion when patient comes. So if patient has a smoking habit, patient had obesity, we always request them to follow smoking cessation diet, cessation programs, so they can quit smoking and better take care of their health. Obese patient, we also want them to stick with their diet programs if they can follow any diet, and to be better in their health and for future life. And here we end with our thorax and cardiovascular examination. And thank you, Summer.